Hey guys, welcome to Sarah Has Questions. Today we're talking about perimenopause. If you're in it, you know it. It has every symptom under the sun, and yet there's not really a diagnosis for it. Why is that? What's the deal? Let's talk about perimenopause. I have a ton of questions. Let's get into it. I'm Sarah King, and I have a lot of questions. What exactly happens when you orgasm physically? Will popping a knuckle or a joint give us arthritis? What can we learn from our poop? The size of your body doesn't necessarily indicate your measure of health. Yes. And what are your thoughts on that? Cleansing. Do we need to do anything special to our nether regions? In this show, I get to ask all these questions to WakeMed doctors who happen to know everything about everything. Sarah Has Questions is a production of Capital Broadcasting Company and Mix 101.5. It's presented by WakeMed. Today, I'm so excited for this episode because we're talking perimenopause. And as a 47-year-old woman, I know a lot about perimenopause. Today's doctor is Amantia Kennedy. You are a OBGYN for WakeMed. Thank you so much for coming in today.
Thank you for having me.
And you came in before and talked menopause.
I sure did.
And so now we're going to talk about perimenopause. And the thing about perimenopause that gets me is you feel like you're making it up. Mm-hmm. You know, like and we'll get into the details of this a bit later, but there are so many symptoms. Mm-hmm. And there are days where you wake up and I'm like, did I just not get enough sleep, or is my brain deceiving me and making me a forgetful person? Mm-hmm. You know, am I not sleeping because I drank too much coffee? Like, you don't know. And then you go to your doctor and they're just like, you get dismissed. Mm-hmm. So let's just start from the very beginning. Yes. What the hell is perimenopause?
Perimenopause is the menopausal transition, is the years leading up to menopause. And it's defined by low ovarian function. So during this time, there's a lot of fluctuations in the hormones that happen. Okay. So that's why we're going to talk about how these hormones affect us.
How does perimenopause differ from menopause?
The perimenopause is the years leading to menopause. Okay. It ends after 12 months of no periods, and then you reach the menopause. So until the final menstrual period. Okay. That's when it ends.
So what would be a typical age to start perimenopause?
Mm-hmm. So again, I want to emphasize that perimenopause is not menopause, is the years leading up to menopause. Right. And it ends with the final menstrual period. So women can enter this transition phase as early as 30s. Yeah. But majority of them will enter it in their 40s. Okay. The median age for a woman entering this stage is 47 in the United States.
Okay. And how do you know that you're entering in? Like, what are the signs of I'm now in the perimenopausal state? Yeah.
So because there's fluctuations in the sex hormones, estrogen and progesterone particularly, which are the hormones released by the ovary, women will experience abnormalities in their menstrual cycle. Mm-hmm. And we actually have two phases of this menopausal transition or perimenopause, the early stage and then the late stage. The early stage, during this time, women will start to experience some irregularities with their periods. Sometimes in the very early stages, they may have more frequent cycles. Mm-hmm. And then they're followed by more sparse, spaced out cycles by more than 7 days in length apart. And then that is followed by maybe you can skip a month or so. And then they enter the late stage when they're starting to skip more than 60 days.
Okay, so 2 months. Once you skip 2 months, you're getting closer to actually getting to the land of promise, the no period land, which sounds awesome.
And we can predict that when women enter this late stage of the perimenopause, they will achieve their final menstrual period within 2 to 3 years.
Oh, interesting. Okay. All right. Well, and so let me ask you this. If when you say skip a period, does that mean no blood at all or just a very little amount of blood?
Skip a period means no blood.
At all. Mm-hmm. Okay. All right. I want to go through the symptoms, or maybe, and you can tell me, this is the part that blows my mind. Mm-hmm. So maybe you can shed some light on why this is happening. Okay. Yeah. So, and please add your own, because there's just so many, and I don't understand why there are so many. Mm-hmm. But we'll start with the first one, which is brain fog. Why is brain fog associated with it? And honestly, how can you tell the difference between brain fog and not enough sleep? Like, it's just so ambiguous.
Mm-hmm. Yeah, absolutely. Brain fog is actually a very common symptom of perimenopause, and up to 40 to 60% of women will experience this. And it's a collection of cognitive symptoms like forgetfulness, difficulty focusing or concentrating, losing objects, difficulty recalling names or verbs, or I can't think of the word.
The worst.
Yes. So it happens because the fluctuations of the hormones, estrogen and progesterone, we know has receptors in the brain.
Okay.
And there's part of the brains that get affected by this, including neurotransmitters. And we're going to talk about that a little bit later.
Okay.
But women have this, think of it as a computer getting a reboot, and they're just not processing the information as quickly as they used to.
Okay.
When women were tested with actual formal tests, they did score a little bit lower on attentiveness, concentration, and verbal recalling, but they did not have a decrease in higher cognitive functions like strategic thinking.
So you don't lose intelligence.
You do not lose intelligence.
Gotcha. Well, that's good to know.
Yes.
And does it ever come back? Does the brain fog ever go out to sea, basically?
Good news, it does. It reverses.
Good. That's
Once
awesome.
we reach menopause, it does reverse for most women.
So we really are kind of getting a reboot.
We are. Think of it as a reboot. And our brains are plastic. They go through different changes based on our experiences, and they're always changing.
Weight gain is another symptom. Gaining in and of itself is one symptom, but why is it always in the belly?
Yes, that's called adipose fat tissue. And that is because as we transition into this phase and we're having these fluctuations in the hormones, let's not forget we're also aging. And that in itself can cause decrease in muscle mass. And as I've mentioned before, muscle is the largest organ of energy expenditure. And so when we're inactive, like we don't diet or exercise, or even when we do diet and exercise, because a lot of times women will say, I am doing everything I did before and I cannot lose weight. I'm actually gaining it.
Oh, girl, that's me.
During this transition phase, though, because of the lack of estrogen, and estrogen does have receptors in the muscle, we have an acceleration of this energy net deficit that we are, or actually net gain. So we are gaining more weight than we're losing the weight because of the muscle mass is we're rapidly decreasing that. It stabilizes in the menopausal years, but especially during this transition phase when we're having this hormone decline, it's a little bit more rapid. So we're starting to get more weight.
And so it's super important to keep the muscle then, yes?
Yes. And that's when we highly recommend strength training exercises.
Okay.
Which is not only beneficial for your cardiovascular function, it's beneficial for maintaining the muscle mass.
Yeah.
Because remember, even Arnold Schwarzenegger, he's going to lose some muscle mass as he ages.
But he had a lot to start with.
He had a lot to start with, for sure.
Which is what you're saying,
Yeah.
you know? The more you have and the more you can lose, and it won't be as detrimental.
Right. And the goal for strength training exercises is to maintain the muscle mass so you don't lose it as rapidly during this phase.
I see. Okay. Next up, we have sore joints.
Yes.
So
It's real.
It is real. I find as I'm going through this perimenopausal state that it's only certain weeks,
Right.
which is really interesting. Why is that?
Yeah. It's, again, we talk about fluctuations of the hormones. Each cycle will be different.
That's
It's
true.
a time of a chaos in our body. So some months you may have more estrogen than other months. And when you have less estrogen in your body, and estrogen has receptors all over our body,
so it's in
including
your
our
joints
joints.
too. Yeah.
It does affect our joints.
So am I
have more of
feeling
like an-
inflammation there, or am I feeling lack of fluid?
No, it's inflammation.
Okay. So would an anti-inflammatory diet help with this?
Absolutely.
Okay. All right. Itchy skin. Some women complain of itchy skin. Does that, is this something that is real, or are they making it up? They just need some lotion.
No, it's real because as we do age, our skin gets thinner. And actually, we do have estrogen receptors on our skin as well.
Estrogen's everywhere.
Everywhere. And so women will have drier skin and thinner skin. So some women can have a little bit more exacerbation of the symptoms than others. And everybody's different. Not everybody's going to have all the symptoms at once. But dry skin is one of the complaints. Yeah, for sure.
And there's also, I'm reading, my producer put this list together, and I'm reading through this, and here's one. Bugs crawling on you. Some people get the sensation of, have you heard of that before?
I have heard of it before, and some women have it like it's not as common.
Yeah.
I'll say that. But it goes with the dry skin.
I would think it's got something to do with your nerves as well, because it, the ends.
Well, it has to do with with hot flashes, which is a very common symptom.
Yes.
Has to do with vasodilation.
Okay.
Of the blood, like the little capillaries. So that could be part of it
Why
as well.
it feels that way. Okay. This is one I have, phantom smells. I'll smell stuff and no one else will smell it. And this has all started in the past 5 years.
Yeah.
Have you ever heard of that?
I have heard of that. And, actually, I heard one woman saying that she smelled like there was smoke in her house, and then she would go to her children's room and her adolescent, and like, "Did you smoke?" And they're like, "No, we didn't. We are not smokers." But it is. Do we understand it all? We don't. We have so much ongoing research as we speak.
Oh, I bet.
Regarding a lot of the symptoms, because as women, we do demand more research, and we do demand some answers to better help our lives, for sure.
I have just recently heard that even in rat studies, they didn't study female rats. Can you? What?
It was in 1987 that FDA required researchers to actually study drugs in women.
Yikes.
Only.
Yikes.
Everything was based on male studies as well.
Chihuahua.
So, we were alive, both of us.
Yes.
So, yeah.
I was in elementary school at that. It makes my blood boil. Were they curious? Were we that confusing to them that they thought they just couldn't figure it out? Like, that says a lot.
Well, either confusing or not important. I don't know. Or
maybe all those things.
Yeah, all those things. I don't know.
Does it make your blood boil?
It does a little bit.
Oh, it makes mine really.
No, it does a lot.
Okay, thank you. Let's be real. You're mad.
Let's be real.
We're all mad.
We are. But the good news is that there's so much ongoing research. More is coming.
That's what makes me excited for our daughters.
Yes.
Because when they enter into menopause, it's going to be a different world, because by that time, we'll have another decade or so, well, actually numerous decades of research, and they'll be the beneficiaries of it.
Absolutely.
And then that's exciting. And I think what our generation's big thing is we need to just bring awareness to them. Don't let yourself be dismissed.
Absolutely. That's so important. That's an important message.
And we were talking about this next symptom. I've got two more. That you mentioned that you have issues with. I don't, because I would do a morning show at 4 a.m. every day. So it's sleeping issues. I never have a problem falling asleep, but I know a lot of women experience insomnia.
Absolutely. This is actually when they studied the 4 most common symptoms of the menopausal transitions.
Yeah.
Hot flashes, night sweats, difficulty sleeping, which include insomnia, genital urinary symptoms.
Oh, like leaking.
Not only leaking, but vaginal itching, dryness, painful sex,
yes,
etc.
Okay.
Urinary tract infections, etc. But also mood changes, irritability, anxiety, depression. So those were the 4 most common symptoms. So let's talk about insomnia.
Yeah.
It's a very common complaint, and actually it can be quite distressing for a lot of women, because lack of sleep can cause irritability the next day. It can cause decreased focusing and concentration. So your coping mechanisms are diminished as well. But we know that estrogen has receptors in the brain. We know that it affects parts of the brain that control some of this circadian rhythms.
Okay.
So a lot of times women will suffer from insomnia.
You were saying that off air, you were saying that they're trying to pull estrogen from places. What were you saying with that?
So what our brain does when we're kind of going into this decline of ovarian function, because that's what perimenopause is, our brain, in order to compensate for it, starts to express some more receptors for estrogen so that it tries to catch as much as it can.
So it creates more receptors.
It creates more receptors.
Oh, kind of like an alcoholic. Whenever they have too much alcohol, they create more receptors, and then when they don't get it, they get crazy.
Right. So they do. It is trying. Our brain is trying to compensate for it, but there is always decline.
Right.
So a lot of times women will suffer from insomnia, and it's a very common distressing symptom.
Yeah, it's miserable. I mean,
It is
not being
miserable.
able to sleep has to be miserable.
Yes.
So is the same thing at play here when it comes to mood and the mood swings?
Absolutely. We know that estrogen also affects the neurotransmitters like serotonin and dopamine. And when you have less serotonin production in our in our system, then we feel more depressed. We're in a more depressed mood.
Oh, that honestly, like I'm reading through this and it seems like a long list, but I have a lot of these.
A lot of women have them, yeah.
Yeah, and it's not like every day. And that's what makes it so frustrating is like it's some days you feel normal and then some days you don't. And you're like, where is this coming from?
Right. And a lot of women feel alone in this. Like, is it me? Am I going through dementia? What's going on?
Exactly.
Right.
Exactly. Last symptom is decreased libido.
Yes. Remember, estrogen and progesterone are sex hormones. So naturally, when we have a decline in our sex hormones, we also have a decline in our libido. But as we talk to women, libido is very complex for us women. It's
Yes,
not
it
just
is.
physical, it's also psychological. So it's important to address how they're feeling, how they're doing. What we know now is that, as women, we take on our lives as adults and we compensate and kind of suppress some of the things that are a nuisance to us. But as we're going through this transition and we're having this depletion of our sex hormones, we don't have those coping mechanisms that we used to. And all of a sudden, we don't feel like taking on any more emotional
Yes.
burden for us. And we don't feel
Yes.
like taking on the slack of our partners, for instance.
Oh, yeah, picking up socks.
So exactly. Things that didn't bother us before.
Yeah, but all of a sudden it puts you in a rage state.
It does.
Yeah.
And the thing is, it can be very confusing for the partner as well because, they also feel rejected or they feel that I don't know this person anymore. Like, who are you?
Right.
But I think that during this time it's very important to have an open communication with your partner so that you can have the support. Also, with the low libido, and as I mentioned before, during this transition times, we also have genital urinary symptoms, and that includes vaginal itching, vaginal dryness, and sometimes sex feels like a sandpaper. A lot of times women will describe it as. And so when you're not feeling good, and then physically you're also not feeling good, then you're not feeling like you need to be intimate.
Yeah.
But what I do want to encourage women that are listening right now is that there is help. Being miserable is optional at this point. There are many options that treat the symptoms. And also, there's not just one medication can help it all. It can be a multi-system treatment. It may involve more than just one physician.
Okay. You made me think of two further questions. One, your partner, yes. Talk to your partner and let them know where you are and all those things. What about colleagues at work? Like, this is going to affect your work. And for me, that's the hard part because you're like, I don't know why I can't remember anything today. So do you have any suggestions for those moments?
Well, I think that the more we talk about this and the more awareness there is, I think the more grace it will be in the workplace as well. And I think that the more women talk about it, I bet you if you talk to one of your colleagues that is the same age as you are, they will completely understand.
My female colleagues get it.
The female colleagues will get it. But as we're bringing our partners during this discussion,
That's a good point.
and educating them as well,
That is a
and
good
they have
point.
partners, they will be more understanding because they have that at home.
Yeah, it's the old adage: you educate women, you educate the world.
Exactly.
Because we educate everybody.
Agreed.
And then you were saying there's treatments. Hormone replacement therapy got a real bad rap in the 90s. And I know there's politics and all kinds of stuff behind it. I think, in fact, PBS is coming out with a special on menopause and the whole hormone replacement therapy. So is it good or bad?
So in the 90s, you're right. They did do Women's Health Initiative. They did do a large study where they included a lot of women, and they thought if we give them hormone replacement therapy, it will help their cardiovascular function. What they found, and they stopped the study early, is that actually they increased the rates for stroke. So they stopped the studies. So as soon as media got a hold of that, then everybody took it off the market, and nobody wanted to prescribe it anymore.
Right.
And actually, we had a generation of physicians, a gap in the training during this time.
Okay.
But what they found is that women were continuing to have these symptoms and they were not being treated. And nobody was listening.
Yeah.
So they said, well, as more women entered the workforce as well, and we wanted better care for ourselves, then we looked and they said, let's look at this study. What was about that study that caused this abnormality that we did not predict?
Right.
Well, what they found is that the average woman entering that study was age 65.
Oh, they didn't even bother with the 30s and the 40s and the 50s.
So what they found is that we know that once you reach a certain age alone will make your vessels rigid. And if you have risk for cardiovascular disease and you're forming plaques, adding estrogen to that is going to make those unstable and increase the stroke. But when they looked at younger women in their 50s, like within the first 10 years of reaching menopause, they actually found lower mortality rates for all across the board. So then more studies came along to actually look at the benefits of hormone replacement therapy. So the more we learn about it, the more we are willing to prescribe it and educate the newer generation of physicians.
That is what's so frustrating about the medical industry is the fact that these studies, they depend so much on the design. And we as lay people can't really dig into that. And we don't know. And so we're at the mercy of everyone doing their homework.
Absolutely.
Are there any, let me go back to treatments before I move on. So talk briefly on the types of treatments and hormone therapy.
Yes.
Like, what do these look like?
Yeah. The hormone replacement therapy is very beneficial. And again, as I mentioned, that the estrogen and progesterone affects not only biologically as the symptoms, but also psychologically. So for women that are having issues like increased anxiety, premenstrual dysphoric syndrome, ADHD, they can actually benefit from being on hormone replacement therapy.
Great.
That may be another adjunct to whatever is their treatment currently, and that may be beneficial for them as they're going through these transition years. There are multiple combination of hormone replacement therapy, but when I explain it to my patient, I said there's systemic hormone replacement therapy, and then there's a local hormone therapy. The systemic therapy is your whole body sees it.
So it's like a pill or
It's
something.
like a pill. It's a patch. Is gels. And if you have a uterus, you need progesterone for to help with maintaining the lining of the uterus to decrease the risk for endometrial cancer.
Oh, yeah.
But if for women that do not have a uterus, then you can just use estrogen alone.
Got it.
There are some women that have contraindications, and they should discuss with their providers whether they're candidates for that. With the local therapy can help with like those genitourinary symptoms.
Yeah.
And that's local estrogen. It can be given effectively without progesterone because it's not systemically absorbed.
I see.
There are other hormone therapy in the market that are local, like DHEA is one of them, that is a steroid that converts into estrogen and testosterone locally in the vaginal tissue.
Okay, so are you putting this in like a gel inside your vagina?
It's like a little bullet, yeah. It's like a little...
like a suppository.
Yeah, a suppository, yes.
Okay.
And then there's the ring, there's gels, there's different combinations.
Okay.
But talking about non-hormonal therapy, because there's other women that cannot have hormones or do not want to have hormones. And there's other options as well. There's non-hormonal options to manage depending on what their symptoms are.
Yeah.
There is a newer medication that helps with hot flashes, and it's non-hormonal, specifically targets the part of the brain that is responsible for thermoregulation.
Yeah.
And there is other non-hormonal medications like anti-epileptic medications. There are the medication in the SSRI or SNRI, the antidepressant medication group.
Okay, so you have a lot of choices.
We have choices, and it tailors to what the most bothersome symptoms are to you.
Man, our grandmothers would love to hear this. They would love to have been a part of today.
Today,
Just
yes.
like we're going to want to be a part of our daughter's future. I want to talk about diet. Is there any diet recommendations you can make for someone going through perimenopause?
Yes. What is proven scientifically to be most beneficial is Mediterranean diet and diet that focuses on lean and plant-based proteins.
Okay, great. This is probably my last question. When it comes to determining whether or not you are in perimenopause, is there a blood test that you can use?
That's a good question. So we typically clinically diagnose somebody based on age and their menstrual history. However, there is a group of women that either have a hysterectomy or they have an endometrial ablation or they have an IUD and they've not had a period. There are a couple of hormones that we can check. The anti-Mullerian hormone, which is the hormone that is released by the early growth of the follicles. And when it reaches undetectable levels, we know that a woman is in menopause.
Okay.
Or the follicle stimulating hormone. But again, those are more helpful in women that are 48 years old or older.
Right, but you're saying that you can detect menopause. Can you detect perimenopause?
Not accurately.
Great.
There's not a particular test that says.
Yeah, but it's mostly you have to sit with your doctor and to go through your symptoms. And how do you get your doctor to talk about these things? Because I know when I went to my doctor the last time, first time ever, do you still get your period? And that was all that was mentioned. And it was the nurse. They never gave me any real, do you want to talk about what's going on?
Yeah.
Have you noticed any of these types of things? Is there any kind of work going towards doctors just to be better doctors when it comes to women in perimenopause?
There is more awareness amongst us, and a lot of us are trying to re-educate ourselves about all of this new research that's ongoing. But another thing that I do want to mention to patients and women in general is that, empower yourself. If you have symptoms, don't just mention them at the end of the visit. That's very important because a lot of times women are too shy, or I don't know why they don't, talk about their symptoms. And some of them, I feel like it's in their head, or they're made to feel like it's in their head.
Well, the doctor comes in and is typically get into business. You come in and it's pretty quick.
Right.
And so you feel like they got to get their job done first before you can get to your questions. You're saying when the doctor walks in and say, let's talk before anything starts.
Yeah, absolutely.
Hey, you're allowed to tell them what to do. You're paying them.
You are allowed to. That's why you're there. They're there to educate you. But also do not have other problems. And then all of a sudden at the end of the visit, you mention, oh, but I have this and this and this. Make it a point to actually discuss your symptoms, only your symptoms. Just go for it.
Oh, just go make an appointment just to talk about
Right.
that.
I have a lot of patients, now that there's more awareness, a lot of my patients come in for menopausal symptoms or perimenopausal symptoms.
Love
and
that
we talk
idea.
just about that. And I think that's what it needs to be.
There needs to be advertising for that. I'm sorry. Marketing needs to go into the fact that, you can just go to your doctor and you can just talk to them and ask them questions.
Absolutely. And your gynecologist will pick up on, based on, as I mentioned, clinically, part of the vital signs for a woman in a gynecologist's office is your menstrual cycle.
Okay.
And that will tell us quite a bit of where you are in
So
that
look
stage.
at your calendar and don't forget, like I do every time, when was your last period? Darn it, I knew I was supposed to look that up. Thank you so much. This has been, last time you came with menopause, I learned a ton. Didn't think I could learn any more, and what was I thinking? Of course I could. Thank you so much.
Thank you for having me.
Isn't Dr. Kennedy just the best? She was also our guest on the menopause episode at the end of season 1. Check it out. It's an awesome episode. You can find out about her and WakeMed Women's at wakemed.org. Please share this episode with someone who needs to hear it. If you or your friends are in the perimenopause zone with me, you're probably already talking about it. Hit the share button on your podcast player and pass it on. See you next time.